The proceeding will
It sticks. Okay, good to see you. Thank you for coming in. We've got a hard stop today because we've got health orals downstairs, which starts at 11:30. So we've got two panels. So we will finish at 11:25. So we will take this panel until 10:40. So if we don't all ask all of you the same question, please don't be offended. And also keep it brief, as they say. Is that a polite way of putting it? Sorry. Right. Tell us when you're ready.
We're ready.
Hit it. Order, good morning. This is the Health and Social Care Select Committee for the second day in a row. Yesterday we were talking about pandemic preparedness, but today we are talking about men's health, which is part of our ongoing inquiry into that subject. This is the third evidence session of that inquiry, and it's an opportunity for us and our guests to explore health inequalities between groups of men, as well as their health across the whole of the life course. Of which I'm potentially halfway through, I suppose, having just been 50. Anyway, I digress. We have a good panel of guests, and we have two panels of guests, but our first panel is currently in place and primed and ready to go. We have Ceri Durham, who is the Chief Executive Officer at Social Action for Health. We have Dr. Veena, Raleigh, who is Senior Fellow at the King's Fund, and we have Dr. Justin Varney, who is Director of Public Health at Birmingham City Council. Nice to see you all. Thank you very much for coming in. It's a cross-party committee. We will whiz round the table. We'll probably run this session, the first panel, until about 10:40, and then we'll change over because we have health oral questions downstairs in the chamber today for those who are watching outside. Let me start with probably yourself, Dr. Raleigh. Health inequalities was the thread that ran through pretty much all of the submissions that we had on our major prevention inquiry, which we are doing as well. And many of our inquiries overlap. There are common threads to them. Could I ask you, which areas of health inequality do you think have the biggest impact on men's health and the outcomes for men?
So some of the areas that have the biggest impact are cardiovascular disease, some cancers, lung cancer, and I'm talking about conditions that have a big impact on both health of men and inequalities in men's health. So overall, CVD accounts for about 25% of the difference in life expectancy between most and least deprived deciles. That's at a population level. In terms of these conditions, it's important to remember, of course, that a very high proportion of them are preventable. About 80% of CVD deaths are considered preventable. Lung cancer, COPD are associated with smoking. And of course, the impact of these is much greater in more deprived areas. So CVD mortality rates are 3 times higher in the most deprived decile of areas compared to the least deprived. So big impact on both men's health and inequalities in men's health. And although in terms of the number of deaths, it has less of an impact, nonetheless what we call deaths of despair, so 3/4 of suicides are in men, and about 2/3 of drug misuse deaths are in men.
Okay, Dr. Varney, if I may just turn to you, what do you think? Same question to you. Which areas of the health inequality among the guys have got the biggest impact on our health outcomes?
So, I'd agree very much with Dr. Raleigh. I think the other thing to highlight to the committee is that there are inequalities within men as a group. We talk about men as a homogenous group. If we look at particularly mental health, over 51% of young gay and bisexual men have self-harmed before they've reached the age of 18. If we look at incidence of prostate cancer in African and Caribbean population, it occurs much at a much younger age. So there are some differences within men as a homogenous group, but I agree with the point that cardiovascular disease and particularly then I would say metabolic conditions like diabetes linked to obesity, the majority of these deaths could be prevented if we had much more upstream intervention and considered men's health across the life course in a much more holistic way.
Okay, so how has that then changed over time? So, I mean, in the last 5, 10, 20 years, how has this developed, would you say?
So I'd say in general, certainly in my part of the world, in Birmingham, we're not going in the right direction. So we've not seen the gains in life expectancy the more affluent parts of the country have. We're getting better at understanding the granularity of inequalities. So actually looking at the differences between men and not just going, well, this is all about poverty. Poverty plays a really important part. We mustn't ignore the fact that white British poor men do extremely badly when it comes to health outcomes. But actually, looking beyond single identity strands and delving beyond that simple socioeconomic gap is probably where we're making some gains. But as a system, we're doing piecemeal interventions, small projects here that are funded in non-recurrent ways that don't get mainstreamed. And that is a challenge for anyone that's working the system at the moment, whether you're in the public sector or in the voluntary community sector. You're lurching from non-recurrent intervention to non-recurrent.
Between you and Dr. Raleigh, sitting next to you, Dr. Raleigh, you look at the national the global picture through the King's Fund. Dr. Varney, you're dealing with it at the coalface as a DPH. What has gone wrong? And then to put it in a positive context, what should we as a committee be recommending as part of our men's health inquiry to address what Justin is saying? Just go to you, Dr. Raleigh.
Over the past 10 years, health inequality has been widening, and that's been amplified by the pandemic. And what we're seeing increasingly is that the deprivation and geographical divide is widening. And in fact, in the last 2 or 3 years, deaths from heart disease have actually been rising, consequent to COVID. And I think where we've failed perhaps over the last 10 years is we've taken our foot off both the pedal on prevention and in terms of really seriously targeting inequalities and the causes of it. And I'd agree with Dr. Varney that obesity, for example, is the new sort of threat to health and inequalities in the way that smoking was. And of course, smoking still remains one of the biggest killers. 25% prevalence of smoking in the most deprived decile.
Why is the foot off the pedal? Is it want or is it means?
I think it's a bit of both. So budgets for public health have been significantly cut during the austerity period, and the focus has been much more towards delivering care, dealing with waiting lists and so on, and that's pretty much where we are now. And at the same time also, I think to address inequalities, obviously healthcare and public health have a big role to play, but there are the wider determinants, and this we're serious about tackling the ever-increasing widening inequalities, which actually are much bigger in this country than in many other high-income countries, then we need to have a cross-government strategy for tackling health inequalities. We need to be addressing child poverty, fuel poverty. We have a population now that, both in terms of childhood and adult health, that has an appalling population health is in a bad state in this country.
You mentioned smoking twice in your answers. The smoking and vaping bill will, we are led to believe, come forward at some point in all of our futures. What would you say then to those who say that the smoking and vaping bill is unnecessary, it's nanny state, it's banning things?
I think with respect to both smoking and the obesity issue, the nanny state argument, we need to be firefighting on these fronts now. What's happening, the trends in childhood and adulthood obesity are truly alarming. And I think just to say that this is nanny statism, to intervene, to influence, food additives, for example, fat, sugar, salt, and so on. We really need to be doing this and tackling it hard. The reports on this are absolutely alarming. And we're building in a generation that's going to have poor health.
Well, Dr. Raleigh, you've cheered us up to kick off the session. Excellent, thank you for that. And they say I'm half empty. Anyway, right, let's bring in James Morris, who's very half full.
One of the things we've heard from evidence and in previous sessions about men's access barriers to access to healthcare. What do you think are some of the prime barriers to men accessing healthcare, Dr. Varney?
If I start, and I'm sure Ceri will want to come in on this. I mean, I think there are common barriers, particularly for men when we talk about access, because we build services around staff rather than around the people that use them. So, and I trained as a GP before I specialised in public health. GP's practices run until 6 or 7 at night. Extended hours goes to 7:30. If you're working, that's very hard, even if you can get an appointment to get to it. Hospital appointments are scheduled during a Monday to Friday. So men are being asked to take a choice between the money that they earn and getting to an appointment. And then we are not seeing, and I'm very grateful to see the new task force on occupational health established under Dame Carol Black. I think we have not addressed the issue of workplace health systematically or consistently in this country. And the 99% of businesses in Birmingham are small and medium enterprise. This is not about FTSE 500 occupational health. This is about how do we help corner shops, fast food takeaways, small employers prioritise the health of their employees. Because like children in schools, if we don't get workplaces' health right, we won't be able to support men to get their health right.
Ceri.
Morning, thank you. I work at Social Action Health, a community-based health charity in East London, in Tower Hamlets, a borough that most people know has very high levels of poverty and deprivation. We recently ran a community health day. Most of the people coming to that were men who were working as refuse collectors, market traders and similar, who were just not able to get access to a GP during normal working hours and similar. We actually ended up sending about 3 people on different days actually straight to A&E because their blood pressure readings were so high. These were people who had absolutely no idea that their health was in that state.
Right.
So I think there is definitely something about the access, in terms of time and working hours. Another thing that was absolutely key for that particular day, and I think it's a good example, was the language. Most of the men were Bangladeshi, which reflects our local population. In terms of their written and spoken levels of English, the confidence using English and navigating very complicated systems at the GP, which now require you to book online very often, means people are not going to actually access healthcare in that way. Because we had bilingual staff there, they were actually able to explain the tests, explain the importance of them, and signpost people appropriately. But I think that just gives a demonstration of some of those key factors that I want the Commission to be aware of. Yeah,
that's really. Can I just come back to? So, do you think, practically speaking, that we might be able to address some of the access issues if employers take more responsibility for their employees? And what sort of practical recommendations would you make on that?
I mean, there's very strong evidence base that occupational health, access to occupational health in employment settings has a good impact. It's cost effective. What we haven't cracked is how to make it accessible to small and medium enterprise. Right. There are lots of things that you can do, but I would say in essence you can't yoga your way out of bad line management. So it is important to recognise that workplace health is not just about getting people physically active, the healthy eating, accessing smoking cessation in work. It is also about fundamentally the environment in which you work. And we've seen significant increase of mental health related to stress and anxiety in the workplace as people juggle portfolio careers, all of that space. But it's an area where there is an evidence base to pull on. And again, going back to the previous question, we've seen the appetite for work and health go up and down in terms of policy and commitment and sustainability and investment.
And the issue around, Dr. Varney, again, you said that there are issues are in different communities. When we talk about inequality for men, we're not talking about a homogenous group. What are the distinctive challenges around getting groups that would feel reluctant about accessing health services? What can we do to kind of get rid of those barriers?
So I think certainly in Birmingham we've spent a lot of time working with communities and engaging directly with them, and particularly with Paula, if I may say, when you were there as a cabinet member, we worked with the community during the pandemic to engage them, and that's got to be the first step. But on the other side, we've got to work with healthcare professionals so that they recognise the inequality, can talk in ways that people understand and connect with those communities. And then the final element is in policy, we've got to talk about it. Disabled men experience higher rates of domestic abuse than non-disabled women. That's been evident now for over a decade, yet we see it not reflected in a single bit of policy action. So we need that triumvirate of working with communities, educating professionals and having a policy landscape that recognises that you can't have a homogenised approach to inequality.
Mm-hmm.
I think I want to just pick up on that in terms of funding, and I know it's a factor that community-based organisations like myself go on about, but I've had discussions this morning with Dr. Varney and Dr. Raleigh. We know from COVID and other interventions that community-based approach works, working with communities. But at the moment, the funding is so sporadic, you cannot plan any long-term community interventions. For the health day I've mentioned before, that came up, 1 minute, can you do it next month? We can do that. But if we want to have sustainable interventions that actually meet the communities that need them, that funding needs to be looked at in a sustainable and long-term way.
Okay. Dr. Raleigh, anything to add to?
Just very quickly, I'd like Dr. Varney said, I think I'd highlight the point of heterogeneity between different groups. So, we assume that all ethnic minorities have a similar profile. They don't. They're very, very diverse, and the differences between different minority groups are actually greater often than the differences relative to the white British. If you look at the socioeconomic differences, the Indians and Chinese now are doing relatively well, even compared with the white British on some parameters. And at the other end, you've got very deprived communities, Black, Pakistani, Bangladeshi. And I think I would agree that reaching out, there's a lot to be learned through the COVID pandemic of how you induce behavior change in communities, how you bring reluctant groups forward to get your COVID vac. The same approaches can be used for public health messaging. And one other thing, the gender difference between, of course, women will very often go to see the GP because they've got children, and men won't do that.
Thank you, Chair.
All right, thanks, James. Right, Rachel Maskell.
Thank you. Thank you ever so much. We've known about the inequalities which exist for a substantial amount of time. I think back to the Marmot report as well, over 14 years now since its publication, and yet we still seem in this bind around addressing the inequality. So I'd like to start by asking about how do we improve the literacy which is required, the understanding which is required, and particularly thinking about making policy around this, and of course not just across the health system and with health professionals, the public, and also, for instance, employers. Perhaps, Justin, I can start with you.
So I think it's important when we talk about health literacy to unpack it just quickly what that is, and the experience we've had, particularly in Birmingham through the pandemic, was we assumed a level of basic biology understanding up to kind of primary school level. And when we were talking about vaccines, we very quickly realised people didn't understand what their immune system was. So there's a kind of health education, what is your body, how does it work? Then there's can I navigate the health service and understand what a GP does or a pharmacy? And that's how the NHS talks about health literacy. And then there's when you're sat in front of a healthcare professional, how do you describe your pain? Because as a doctor, I'm trained to recognise certain words. If it's crushing in your chest, that's your heart. If it's sharp and stabbing in your chest, that's infection or it's muscular. It's unlikely to be your heart. So those three elements of health literacy need to be brought together. And we need to do that through systematic approach in education. And this is as important as teaching people maths and English. It should be embedded from the start of life through, but also retrofitting it through adult education and helping healthcare professionals understand the person in front of them probably doesn't have even GCSE in biology, and therefore a lot of what you're saying just goes over their head, and that's not fair. That's not patient-led healthcare, which is what we've committed to deliver.
What's the policy interventions that you'd want to see in that arena?
It's a very good question. I would say, in this country, we've done more. You referred to the Marmot review. Before that, there was the Black review and so on. We go back. We have a long and very good track record here. Compared with most high-income countries, we've had a longer period of trying to tackle health inequalities. We know more about it than most countries do. And that's why it's really sad to see, that we are in the position we are. I think in terms of the policy interventions, we should be learning from what we've done before that's worked. And one of the things that did work, and this is not a party political point or anything, is the fact that you do need a cross-government approach. I mean, that's the key Marmot message, and it remains. And the inequalities start in childhood and infancy. You've got to build on from there. So I think we've got very short organisational memories. We need to be revisiting some of what we've done here that has worked and learning from there. We don't need more research or anything. We've done it before. We need to be doing it, and much, much more aggressively. Because in the wake of COVID, not only are health inequalities widening, but with long COVID and the impact on the long-term sick and so on, we're just going to see a very widening chasm. And that chasm is actually worse for men than it is for women. So the gender difference in life expectancy is worse in deprived areas than it is in the more affluent. By 1 year, that's a lot. And many of these deaths are preventable. I'd also say in terms of, very quickly, last point, in terms of population health literacy, we need to be doing much more in terms of awareness raising. 1 in 4 adults has hypertension. ONS statistics of just 2 weeks ago showed that 1 in 5 adults either has or is at risk, is pre-diabetic. That's a really scary statistic because it's a lifelong killer. And people need to be, aware of this. And again, there's research that shows that these conditions go undiagnosed in the least risk groups, because the GP may see an overweight or an older person and advise them. But if you're young and not seemingly a high-risk group, you're not aware, especially if you're male. So I think we need to be doing much more of aggressive information awareness raising, both at the community level and at the national level.
Thank you. And Ceri, being out in the community, what would you add that you'd want to see in the policy arena?
In terms of the policy, I'd just like to reflect what Dr. Raleigh said about the Marmot principles. We're very familiar with that and the social determinants of health, and I think we need to go back to that, and it is the life course, starting at the youngest age, and having that, universal services for everybody is the best way to get those messages out. In our recent survey, just at the other end, about mental health and men's mental health, minoritized ethnic men's mental health, we did a survey of 1,000 men in East London. About 20% of those did not recognise that they were living with what would be described in medical terms as mental health conditions, depression, anxiety, high levels of stress, and so on and so forth. It was just not even on the agenda, so they would never go and access services. So there's got to be, again, those community interventions, those social determinant factors. It's such a broad brush of approach that we need, but we've got to just keep going with that awareness raising from the earliest possible stage.
Thank you.
Brilliant. Okay, Paul Blomfield.
Well, that segues neatly into my question, which is around awareness raising. Are there particular issues? You talked about the Bangladeshi community in Tower Hamlets, but and obviously we can recognise the need for niche targeting there. But between men and women across communities, are there particular issues which make men less or more susceptible to or willing to engage with awareness raising?
I think definitely in our experience, there very much is the stigma of being the strong man. I think that is very prevalent, particularly amongst some of our minorities and ethnic communities. Again, through this survey, that came out very strongly, that men were feeling they had to be strong, they had to be the provider, they did not want to go and ask for help. Our social prescriber work we did reflected the same. When women go to the GP, they're much more likely to be open to what's called social prescribing and actually non-medical interventions than men were. They would much more likely, if they'd got as far as going to the GP, wanted like a tablet, something like that. So I think that is probably speaks to lots of things about our society and culture, but definitely where I am, there's that gender divide there between who's more willing to access those other services.
And are you able to respond to that in terms of the awareness campaigns that you run, so that you're recognising that, and what's worked?
So absolutely, we try and respond to that as best as we can. So, for example, with a lot of our men's work we do in the mosques, and I think that's common for lots of men's groups in communities such as ours, where many men are accessing the mosque. So we were having trouble initially recruiting men to some of our sort of health prevention courses. As soon as we were doing them in the mosque at times that were appropriate, that could fit around people working gig economy jobs, suddenly the uptake was fantastic. People very engaged, 100% retention rate. People really grateful, but we obviously had to go there and make it language culturally appropriate to ensure that accessibility was there.
Justin, you talked about the kind of heterogeneity of men, and we shouldn't obviously see them as a single group. On this issue of how do we get through to people to understand the health risks that they're facing, how effective do you think awareness can be, and how do you think it could be developed in terms of different groups recognising that heterogeneity?
So, I think it's important to kind of say, when we talk about health awareness, the evidence base about the impact of posters and leaflets is pretty poor. So when I talk about health awareness, I'm talking more about conversations, and that is much more effective, using things like community radio, using peer-to-peer advocacy and engaging in that way, and health champions. And we have some great national campaigns. Things like Movember are brilliant at raising awareness. Some of the disease-specific charity-led work, like prostate cancer. And we've seen increasingly those large national charities start to get more nuanced in the way that they tailor their messages, in the same way that private commercial companies tailor to a target. This is not new. It's just applying commercial marketing to a different demographic in the context of trying to achieve behaviour change. I do think there's a really fundamental difference, though, between men and women in relation to their access and their awareness, is that because of the nature of the way society positions parenting, women tend to have much greater contact with public sector professionals, not just in health, but also in terms of education. And each of those kind of making every contact count moments can notice if someone's limping, if they're in pain, if they're in distress. Men have far fewer of those because of the nature in which we societally raise our children. And we have to think about how then do we reach them, and whether that's through the mosque, whether that's through where people still have working men's clubs or sports clubs. It's finding vehicles to talk to men where they are, rather than expecting them to come to us. This is not about hard to reach communities. No community is hard to reach. It's about making the effort to go and find them, go and talk to them in language they understand.
Well, Kerry's point, there's a sort of male kind of self-image which is resistant to that sort of messaging. How do you deal with that?
Well, I think we are seeing, and I think over the last 2 to 3 decades, we've seen significant social repositioning of men's body image and their societal image. And that does contribute in terms of this narrative of invincibility. I think also that caring aspect does make a difference. So I think women are often triggered to do something if it's impairing their childcare. If it's going to threaten my child and I'm not looking after my health, that idea of the carer needs to look care out for themselves first, that doesn't seem to quite work in the same way in relation to the narrative around men. But I think we're seeing increasing numbers of eating disorders in men, which speaks to societal trends in social stigma and social imagery. The impact of social media on self-harm, particularly on young people, we're only just starting to understand. And just purely looking at my Instagram feed, if I believed what men did on my Instagram feed, I would be quite depressed about my own life. It creates a narrative which is unachievable. And I think men do still feel that more, or in a different way, rather than more or less in a different way to men, because of the way our society is constructed.
Dr. Raleigh, if I might, you talked about the obesity crisis, and clearly we're all aware of it. And there are shocking figures of the number of obese children going into primary school compared with those coming out. So we're clearly not tackling it. What's the balance between kind of awareness and other interventions? Because we knew, for example, that cigarettes were toxic in terms of our health for many years. We ran public awareness campaigns. Big Tobacco ran counter campaigns. But it wasn't until we actually intervened that we began to see real behavioural change. What's the balance there?
I think that's an interesting point, because a lot of the evidence shows that if you have information awareness raising campaigns about behaviour changes that are good for you and so on, the uptake is more in more affluent groups. And it's the groups that most need to change their behaviours that actually either don't get those messages or are not responsive to it, which is why the things like the ban on smoking in public health, in public places, and the tax on cigarettes, the sugar tax, reduced sugar consumption, quite significantly. So I think the role of fiscal and regulatory means is that that's a very powerful lever. I mean, it goes back to the point of the nanny state. If, it's a very powerful lever. It's been shown to work, most graphically in the case of cigarettes. And those are some of the things we need to be doing, because I think the people who are at most at risk of health inequalities, the risk factors tend to cluster in those groups. So they will be the groups who both smoke more and have bad diets and have no green spaces to exercise in, even if they have the will to do so or the energy left after a hard day's work to do so.
You're saying are least susceptible to awareness campaigns?
They are less receptive. I mean, it's your middle and upper middle classes that will, you look at the uptake of jogging and gym membership and so on. There's a selective uptake and responsiveness. That's not to say we shouldn't have them, but they're not a sufficient tool on their own. We do need other means of reaching people. And the power of commercial companies is immense, as we know from cigarettes.
Thank you very much.
Cool. Right, we've got about 10 minutes on this session, so let's bring in Paulette and then Paul.
Right. Ceri, one quick point for yourself to answer. What support do community groups need from government to carry out their work helping men who are experiencing health inequalities? I know the funding is a major issue because Justin is my man, I'll just say it, and we have this discussion all the time. But take away the funding element of all of this. Can you answer?
I think, it's very difficult to take away the funding, but yes, I will. I think it's that sustained commitment to that particular issue. Like we've been talking about, not all men are the same, not all groups are the same. So actually working within the local context and actually identifying who are the men who need particular interventions, awareness, whatever, and then run that campaign, that intervention sustainably over a long time with that joint commitment from across, local authorities, into the parliaments and so on and so forth at all levels. It has to be like that, identifying those groups most at need and then targeting that.
Right, thank you for that.
Okay.
And Justin, I'm going to move on to a subject we've talked about quite a lot, integrated care boards. Mm-hmm. How do you believe, through a big system like Birmingham, that integrated care boards can help us not just link in with what's going on locally, but with other parts of the health service and others?
I mean, integrated care boards give us an opportunity to really think as a system, and there are some real advantages to that. And as long as there's stability for a period of time so we can allow them to mature enough to make strategic decisions, I think there will be huge gains. But it starts with the data. So the first thing is we've actually got to start looking at the data we have within the system and starting to report it in a transparent and accountable way. So in our own ICS, we've started to create dashboards that are publicly accessible, where you can cut cardiovascular disease by gender, for example. We haven't done that before. And if you don't look at the data to look at what the inequality is, then you're not going to design your services in a way that meet the inequality. So the first step is actually ICS and ICBs looking at their data in a way which actually goes beyond just what is the population level. And then the second is in terms of truly living up to this commitment to patient-centred care. It's been around for decades, this idea that we co-design patient services with the patients that use them. But if you don't know who your patients are and you don't know who's not coming through the door, that's quite hard to do. So I think the ICBs do give us huge opportunity if we're strategic in using the data, and actually that is driving service design which looks across the totality of a care pathway and looks at the way that different communities and men from different communities interact with that pathway. And there are some emerging kind of good signs of that, particularly in the mental health collaboratives. We're bringing the voluntary sector alongside NHS providers, alongside private providers, and primary and secondary and tertiary care altogether. You start having a much more sophisticated conversation rather than a, please can you see this patient in your clinic and then send them back to me and I'll send them somewhere else. But it's still very, very early days and they need time to mature and really the space and the bandwidth to be able to develop that.
Thank you. And finally, Dr. Raleigh, right, nationally, what can be done nationally to help them both locally and local organisations to make it seem more joined up, because at the moment it does seem very disjointed, and some systems are doing quite well at this, but some systems that really do need to do better are struggling.
Yes, so we've talked about the constraints around funding, which a lot of it comes back to.
Do you feel if you had the funding, that would sort the problem out?
Not entirely. I think what you're talking about is also good practice. And I think there's something about the learning from areas that are making it work, in terms of whether it's at ICB level or where they're working effectively with local community groups. There's something about learning from those good quality, good practice examples and disseminating that as well wider.
And for that you need the funding.
You need funding always helps.
I'll stop there. Chair, back to you.
Very good, very good. Paul Bristow.
Thank you, Chair. Dr. Varney, I was very taken by what you said around health literacy amongst the public. And of course that doesn't just mean knowledge about one's own health. That means understanding the system and the NHS. And I think you've hit the nail on the head. I think there's a shockingly low understanding of access points in our NHS. That's not the public's fault. It's because a lot of the time the old traditional models of a family doctor and all that sort of stuff, that's kind of gone, with population explosion and all sorts of other factors. So and obviously the entrance into the system now could be pharmacy, could be A&E, could be 111, could be the traditional GP model. But to what extent, though, are we looking at this the wrong way around? Rather than trying to re-educate the public around the points within the system they can enter, shouldn't we be asking them about how they wish to access health services?
Yes, absolutely. And I think what we will see is a bit of a cohort effect. So we know that younger men are much more happy to use digital booking systems, and much more digitally fluent and digitally native. But expecting an 80-year-old to accommodate now going online and navigating the NHS app to do their repeat prescription isn't fair. And we've got to, it's how do we shift a system to actually be customer focused and recognise that you can't have a one size fits all, and that's very hard at a national level to do, because at a national level it's easier to have a one size fits all, and that's where I think the partnership between local government and the NHS through the ICBs is quite important. What local government does really well is understand its local people. And actually, therefore, you build that connection. And I would say it because I'm a director of public health. My bridge between. I don't
know Peterborough City Council very well.
Well, I think it's actually one of the great privileges of having moved from the NHS to local government is that you start to be able to influence the wider determinants. You operate in a very different environment. It is an extremely different environment from being in the NHS. But both need to come together and both need to work with patients and citizens and understand that citizens will always be there and there'll be patients for bits of their lives, but they won't describe themselves as patients for all of their lives, and therefore actually thinking about universal and services which are accessible in many different ways is a better solution.
And Dr. Raleigh, have you got any comments on that? And very specifically, do you feel the NHS is it well equipped to do what has just been described? Can it reform and change the way they allow people to enter into the system in the way Dr. Varney said?
Well, I think to some extent the NHS is trying to do that, perhaps not enough. Yes, it needs more of a sort of commercial approach to selling the product. But there are good examples. The NHS Health Check is a good one. And I think increasing access to that, I know at my gym there was a sign up saying you can get your NHS health check down here. So taking it, the service out, and this is targeting, adults in their prime when they're at greatest risk of developing chronic disease. You know what I'm talking about?
I do.
Yeah. And I think taking it out through avenues which are natural habitat places that men inhabit, not necessarily the GP clinic, is one way of doing it. And I think through employers, I think occupationally and through all it should be standard employment practice to look after the health of your workforce.
How do we make individual pinch points, like which are often locally led, like GP surgeries, like pharmacies, do this? So, for example, I feel very sorry for GPs in many ways because they're GPs, but we're expecting them to run mini businesses in many ways, and some do it brilliantly. Cecil Moore Surgery in Peterborough is just a brilliant example of how they reach out to their population. But others, quite frankly, they're brilliant GPs, but they're hopeless because they don't have that skill set. They want to cure the sick, and see their patients. They don't necessarily want to run small mini businesses. How do we change that?
It's a very difficult call, and I think, primary care general practice is under so much pressure now. I think some of these things need to be organised perhaps through central and other routes rather than everything thinking, it needs to go through general practice. I don't think we can add on a whole lot more there. And in fact, the NHS health check, having said what I did say, if you diagnose more illness, then it does go back to the GP. But I think we need to think of imaginatively of approaching and delivering and reaching people through other routes and not necessarily. Men don't like to make GP appointments.
Okay. And just finally, sorry, how do I pronounce your name? Ceri. So, Ceri, I just wanted to. I was interested in what you said about mosques. Peterborough is a multicultural city, but 5 main mosques in our city, 6 now actually. And I think one of the great virtues of the COVID vaccine programme was that they went into places like mosques and shopping centres, etc., to do this. It showed that the NHS can do this. It can do this and make that accessible way. In your experience, the NHS showed it could do it, but will it do it in your mind? I mean, is it in peacetime, if you like, beyond a COVID emergency? Does it have the bandwidth to think that imaginatively?
I think the potential is there, but the systems need to be developed and grown, and I will talk about the funding again, and that needs to be in sustainably to do it. We did show we could do it in COVID, we can do it again, and that I think is what most community groups, religious institutions would want to do. They're very willing to help their populations to have the best possible health, and absolutely would be very, very keen to do that.
Okay. Thank you very much, Chair.
All right, thanks very much. That concludes the first panel. Ceri Durham, Dr. Raleigh and Dr. Varney, thank you very much for being here. If you could slide that way, and if the next panel could slide this way, we will change the names and we will continue. Right, let's introduce our second panel while they're just getting comfortable. We have Dr. Jeremy Davies, who is the Head of Impact and Communications at the Fatherhood Institute. And you can say a little bit about that, maybe, Jeremy, what it does. We have Karla Capstick, who's the Programme Director at Small Steps, Big Changes. And we have Simon Yates, who's the Director of Operations at Place 2B. Jeremy, did you just want to say a very quick word, 60 seconds or so, about the Fatherhood Institute, just for those watching to know the work that you do?
Oh, so we're a small research, policy and practice organisation. You might call us a think tank. So we do research about fatherhood and develop interventions and, lots of...
Okay, Small Steps, Big Changes.
Thank you, Chair. Yes, we're a National Lottery community-funded project. We're one of 5 Better Start sites working in Nottingham, and we're very focused on supporting babies and pregnancy and child development outcomes in sort of that pregnancy through to 4. So our kind of input today will be very much focused on kind of early years, pregnancy, and the transition of men into fatherhood and that parenting space and their experiences of that.
Simon, Place to Be. Tell us about that.
Place to Be is leading children's mental health charity. We deliver mental health support to children in schools, both primary and secondary, and we've been delivering this service for about 30 years now.
Okay. Dr. Davies, let's start with you. What is the biggest barrier to poorer health outcomes for boys, and the role that fathers can play in that?
I think the issue from our perspective is a lack of engagement with fathers by services, which then feeds into a lack of impact on their children's outcome. So it's not just boys, but girls also. So what we have found through our work, we've done successive evidence reviews looking at the antenatal period, the postnatal period. Most recently, we've done one that looks right through to adolescence. And what we consistently find in the evidence is that services are not seeing men as fathers, even when they're in the room, which they mostly are. If you think about maternity services, for example, well over 90% of men attend antenatal appointments. Well over 90% of men attend their children's births. And the evidence is that even when they're in the room, these men are not being talked to as fathers. They're often not engaged with at all. So, I mean, I've heard the evidence in the previous panel. I do think there are issues around fathers' own attitudes and availability to services, if you want to see it in that way. But at the same time, I think there is an issue with services themselves, both failing to reach out to men, going to men where they are, going to fathers where they are, and also when the fathers are actually presenting, they're not seeing them and responding to them in that crucial role. And of course that then has a knock-on effect on those fathers' ability to be great parents for their children and to understand the impact that they themselves can have and that the mother can have on looking after the children's health.
Thank you. Karla, how would you respond to that?
I would absolutely agree and concur with Dr. Davies. We actually commissioned a citywide fathers consultation in Nottingham back in 2020. It was slightly hampered, obviously, by what was happening nationally at that time, but a large number of fathers took part in that for us, just under 100. And we looked at various things like what did fathers want, what were their current experiences of services, particularly in that pregnancy and postnatal period. We asked questions specifically around mental health and also how they wanted to receive information. And what fathers told us was that they wanted to be recognised as an active, if not equal, parent when engaging with services. And exactly as Dr. Davies has described, they're often viewed as invisible, not deliberately, I think, but health services during that perinatal period are predominantly aimed at women and babies, and far less provisions are there for men. And there are no dedicated statutory services for males in the perinatal period at all. Yet, quite obviously, fathers can also feel vulnerable, anxious, concerned, potentially even traumatised if it's been a challenging birth. And there is nothing there to potentially support them in that space. Also, fathers told us that most, this is a system issue. Pregnancy in early years workforces are predominantly female. So some men don't feel comfortable raising issues and concerns that they might have with a predominantly female workforce. And similarly, that female workforce didn't necessarily always feel best placed or well equipped to support the men with the questions that they might have. So there's a bit about workforce training, understanding, and wider peer support as well. I think when we touched a little bit, and this has been my final point, the timing bit, and I think it came up in the previous panel, there is a real golden moment in this point in a father's life. Fathers told us that they would be most proactive in seeking advice and support in the first weeks and months directly after their child is born. In fact, 45% said in that 6-week period after baby's born, I would welcome advice and support about my health and around the health of my child as well. So there's a real golden moment there to engage with fathers, alongside it being potentially an area where they might need more support as well.
Yeah, okay. James, shall we bring you in next?
Yeah,
I think
sure.
you were going to talk about
mental
health and boys, weren't you? Maybe
yes.
Bring in Simon.
So, I'm interested in boys' mental health, and obviously boys face distinctive issues sometimes in the school environment where behaviour gets interpreted in a certain way. What do you think are the distinctive challenges around boys' mental health?
Yeah, I think we work across both primary and secondary, and in the primary age setting, we seem to see about 50-50 representation in our services for young boys. In our self-referral in primary, only about 30% are boys, so already at an early age, boys aren't self-referring into mental health services. When you get to secondary school, only 30% of boys in any of our interventions are represented. So as you go through the age range, it becomes less and less accessible for boys. So something's going on as boys.
What's going on there?
I think stigma is probably one of the contributing factors to this, that it's, boys are still expected to be tougher, maybe not show emotions at all, and I think that's reinforced, sometimes through role modelling, sometimes through social media, that is a barrier to them boys seeking access. I think to build on the workforce element as well, we see 3/4 of mental health professionals are female. There's a high level of a majority female workforce in the teaching profession as well. So access to people who are like you to discuss these issues with is more constrained for boys than it is for girls in areas where they spend most of their time, which is school, really up until the age of 18.
Do you share that view that there's still stigma associated with boys talking about mental health or issues of that nature? Is that one of the barriers you see, or are there others?
I think we've not done any work directly with, obviously we work with very young boys and with babies, but what we are seeing with young fathers is that still that stigma there, and that they are still thinking about how they present in that very masculine way. Yeah. We've again done, and again it was interesting, it came up through Ceri and some of the colleagues in the previous panel. One of the things that we've done in Nottingham is focus on some of our community support groups there to really kind of break down those barriers, and they've been particularly successful with some of our Black and Asian minority ethnic fathers. We've got a fabulous project called Shifting Your Mindset that works in the city, and that's predominantly focused on that particular community and kind of working in a very positive masculinity way. They've run extensive parenting programs. These are often fathers as well who are separated from mother and have very limited access, but they're still engaging with parenting programs, they're still engaging with kind of positive fathers work, and the organisation itself has seen, over 1,000 fathers last year, and worked with over 300 dads in the last year as well on those particular programmes. And they're certainly looking at how they break down some of those barriers that are linked to that kind of stigma of, I must be the provider, I must be strong in that way. And it's been really quite powerful, the work that they've done.
Dr. Davies, do you think there's still stigma around?
Our work is not especially focused on boys and masculinity, but I would say that in general, the way fathers are thought about, talked about, planned for in policy, is that they are providers. That's fundamentally what they're there for. So there is very little focus in our society, I would say, on supporting men's caregiving roles.
Yep.
And of course it's through those caregiving roles, as anybody in the room who is a father themselves will have worked out, it's through that active caregiving that men are most likely to access the soft skills and the things that are not traditionally thought of as masculine in themselves. So, of course, that also then feeds through to their male children. We're setting up men to be a certain thing. You need to be like this, not like this. And the way that is both a cause and effect, I think.
Well, I was just picking up on a point you made about the sort of early years nature of the interventions there, which say, a lack of statutory perinatal services for men, a lack of a role for fathers in that very... Do you think we need to be thinking about some adjustments or redesign of how we think about early intervention to cater for the particular issues that boys in certain groups have?
Yeah, I think that would be a fabulous development nationally if we were to really think about universal services also supporting fathers in the same way that they support mothers. We'd need to think about the equity there. You know, I'm not advocating here that, you know, we should start not concerning ourselves with mum and baby in this period. Obviously, you know, they're of paramount importance. Yeah. But I think that most services do need to recognise that fathers want to be good dads and they want to support their child's health and development, and also they have their own health needs as well. And at the moment, a better joined-up approach to men's health, I think, in that early child and family service period, and policy around that would massively support and help, yes.
And Simon, in terms of the educational setting, do you think there needs to be any adjustments or additional thinking around particular issues that boys face at certain ages in the development cycle, in terms of the way that the CAMS services are organised, or in terms of the way that we're moving to this trend of having mental health counsellors in schools? Is there anything in there that needs to be examined, do you think?
Yeah, and I think the mental health support teams have been really welcomed, and place to be is the mental health support team in primary schools in Manchester, and we think a further rollout of that would be really beneficial. The embedded nature of those teams breaks down one barrier already by having somebody familiar to go and talk to, so somebody who's there in the setting week in, week out. I think one of the issues that we find when children are referred to CAMS is there's an immediate barrier there, and that they don't know who they're going to go and see. There's also something it's anecdotal because there's so few male mental health practitioners, but boys and men are more likely to access and be more open with a male practitioner than they would be a female practitioner. So there's something there about even making those caregiving roles more acceptable and more encouraging for men to go and take those up. I think it comes alongside working across organisations as well. So we work closely with people like Football Beyond Borders, with Greenhouse Sports, obviously who work through the medium of sport, but to try and find different pathways for men and boys to talk about their health. So seeing a therapist might not be the first thing that an adolescent boy might choose to do, but they might talk to their sports coach in the first instance, and that might open up doors for them to go and talk more widely about some of the emotions or feelings that they have.
Thank you, Chair. Right, it's Paulette's time.
Right, I think it might be Dr. Jeremy Davies that I'm asking this question to. In my day, you know, I always say to the panel, I'm only 21 and a half, but when I had babies, men do not come in the room. They didn't come near. If they did, it was frowned upon really, and they didn't get involved. But things have changed a lot now. What do you believe, and it may be yourself, Karla, have I said your name right? Karla. What is it that you believe that we need to do now for young dads, especially, that this really important time of their life, that we include them more? Because historically, it has not been the man thing to do. Thanks.
Yeah, so I mean, you're right. I absolutely recognise what you're saying. And what's interesting, I think, is that this cultural shift has been massive, and it's happened despite policy rather than instead of it. So, for example, nobody told fathers they needed to start being there at their children's births. And yet we've got up to well over 90% doing that. So there has been a massive cultural shift. I think the problem is that our services have not caught up with the reality of how both men and women want to live their lives. So my sense is that fathers do want to be involved actively as caregivers, and then they're not very demanding of services. So you won't find men knocking on the door demanding, you know, I need help, I need this, whatever. They tend to kind of hold back from doing that. But that doesn't mean that they don't need it. And I think there are lots of ways our services, as I was saying before, they're often in the room already. So maybe, change the conversation you're having with him. Look him in the eye, call him by his name, shake his hand, show that you value him as a parent in his own right. It's really, some of it is really quite basic stuff. It's about respect, I think, and that then changes the dynamic, and it opens the door for those men to, if they feel like they need some help, they're much more likely to ask it. We did a survey called How Was It For You? This was about 5 years ago. About 2,000 men who had become fathers in the previous 5 years. And about 2/3 of them said that at no point in the entire perinatal system had anybody talked to them as a father. And well over half said that they had rarely or never been addressed by name. So these men are absolutely in the system, but they're kind of wandering around and as if they're invisible. So I think there's a lot that we can do to adjust our thinking and how are the professionals being trained to make sure that they're seeing these men, that they're having the right conversations with them, and so on. Now, of course, when you start to do that, you then need to be able to do something with those fathers sometimes, because you identify a problem, so they have to then be referred somewhere, and so on. So sometimes the problem is, even when you are good at engaging with a dad, then what am I going to do with him? Because where's the mental health support for fathers that is available and that he can get to?
That's really good. And my final question, I haven't got one for yourself today, Simon, but my final question is to you. The natural thing that I would ask is, what about the employer? How are we engaging? You've made all the right points, in my humble opinion. But Karla, how would you suggest we start involving the employer, where most of our men spend at least 40 to 50% of their time, and yet they have paternity leave now, all access to services? How can the employer be more effective in this area?
I think there's opportunities for employers to think about how they can support fathers in that period where they transition into being a parent. Like you said, there is opportunities through paternity leave. Some of the fathers that we spoke to through that consultation that we did, though, did say that was still a barrier, because although it's there, it's not as flexible. The time is still limited in how much they can then access services. I think as an employer and or as services, you could flip it either way. What do we do to make sure that we talk about fathers not engaging, but are we making our services accessible, and are we allowing fathers opportunities to access things during their working time? That might be a challenge depending on the employer, but I think there is far more that we could do. Certainly what we've done in Nottingham as a commissioner of services, so we haven't necessarily engaged as much with employers, but what we've done is we've asked some of our services to think about offering evening appointments so fathers can be involved. That's one of our speech and language interventions. We've done work in the community. We've done drop-ins, weekends. We've also commissioned some very specific offers that far more speak to dads. It's interesting what Simon was saying around the kind of therapies that boys want to access. We also found that with men, that they're less likely to want to access talking therapies. They're far more happy to access things that are action-based, doing things, making things. But I think that conversation with employers is important, and that opportunity to think about flexibility and to think about dad's role as a co-parent, and the benefits that would have on him, and therefore potentially his productivity and his satisfaction at work and all of those kind of things, sickness. I think there's a bigger question there, absolutely, and a bigger discussion to be had.
Thank you, and I'll hand back to the chair.
Very good. Yeah, we had the Men's Sheds Association in at the start of this inquiry, and they talked about being shoulder to shoulder instead of face to face, and how that encouraged a better conversation. So very interesting. Right, Rachel Askell.
Thank you ever so much. I want to turn a little bit to physical health as well, and particularly around intergenerational health. I mean, in the first session today, we heard from Dr. Veena Raleigh about the health outcomes in adult men, and clearly we know that many of those trajectories start in early years as well. So if I can turn to you, Dr. Ceri Davies, what are the opportunities are there for that intergenerational interaction to ensure that we get our boys focused on their well-being for the future, particularly physical health, but we know it has implications for mental health as well. And many schools only offer something like an hour a week PE, so they're not getting a lot of opportunity for that really physical well-being. What are the interventions and policy interventions that we need to improve young people's physical health? And of course that will have ramifications for improving the health of fathers as well.
I mean, again, obviously I'm going to give you an answer that is about fathers. And I would say, as Karla said earlier, she used the term golden moment about the perinatal period. We know that fathers' obesity, for example, is associated with their children's obesity. At the moment, we're doing nothing to look at men in the antenatal or perinatal period and to assess their physical exercise, to provide them even with basic advice about healthy eating and so on and so on. So I would say, if you were looking for an intervention that would feed through to children, you might look at that, because if you get the fathers and you get them thinking about their own health, and what's crucial when you're engaging with fathers is the most effective method for doing that is to explain the benefits to their children. So when you're talking to a man who is about to become a father, you're not just talking to him about his own health. You're doing that in the context of, think about the effects of this on your child once it arrives, and so on. So I would say that would be an excellent starting point if one was developing a sort of strategy for engaging with children's health and to address some of these challenges, would actually be to start with strategies that engage meaningfully and directly with both parents.
Thank you. Karla Capstick, if I can turn to you. A similar question about how parental health can and physical health can have a bearing on little ones' kind of well-being and that early start.
Yeah, no, I'd absolutely echo what Dr. Jeremy Davies has said there, and I think we've seen that in the work that we've done, that there is that definite correlation there, and I think where we've looked at doing projects in Nottingham that have been focused on fathers, we haven't done as many that have been father specific, mainly because fathers, a bit like my colleague said, was that fathers actually don't necessarily want father specific services. That's sometimes helpful, and there is definitely a correlation between that more physical activity. We've done work with the 2 local football clubs. We've done work with various community groups as well, and they've been very much targeted at fathers in terms of getting them involved with their small child in terms of that more physical benefit as well, and kind of supporting with that. We've also done work around healthy eating, diet and nutrition, and cook and play sessions, and again it depends when those are run though as to whether then father can then access them and can then see the benefits. But I think, as we've already mentioned, that golden moment, that opportunity to talk positively about behaviour change on a men's life, in terms of their health and health wider outcomes. If you talk about it through the lens of their child, they're far more receptive to hearing about that, because they want to be there for their children, they want to be a positive role model. So we've seen more fathers making changes and supporting, smoking cessation, thinking about their weight, thinking about exercising more, because they're linking it to activities that they can then do with their children.
Thank you. And Simon Yates, clearly you will see the correlation between kind of what happens in the home and what happens with people that come and use your services. What recommendations would you provide the committee of how that can be improved? And I think particularly around things like adverse childhood experiences as well when relating to you.
Yeah, definitely. And I think what we're seeing increasingly in school communities now are schools creating the environment that may have formerly been available in a broader community, so having community settings on the school premises where they engage family teams like ours, counselling, NHS services, to bring the whole family into that setting to get them more engaged. And as Karla said, engaging with parents in early years is exceptionally important to a positive mental health of that children going through. We see half of mental health issues developing before the age of 14, so we're talking about primary schools and the very bottom end of secondary schools here. Those community settings are really important because I think they increase the diversity of people that will access health services, and we definitely see that in some of our projects in more diverse communities. And I think it's one of those barriers that is broken down. I think a school is a natural place where people go to either drop off or pick up their children. It's not like going to a statutory service sometimes where there might be a perceived barrier to entry there because of what the implications might be to coming to that setting with an issue about their child. So the informality of that setting, I think, is really encouraging. It also allows the school, local community groups, third sector organisations to come together to provide, again, a range of different options for people to come and to talk about. So we've seen cookery classes, like we've just been talked about, going on in these community settings, facilitated by the third sector, again, to get people involved at the community level. And I think from my own perspective, bringing in fathers to that is really, really important. We do see more mothers attending our parental services. I think going back to the previous point about engaging employers, making some of the parenting services accessible through employment schemes is something that we're really, really interested in looking at, because I think it's another route to try and engage parents, again, where they're spending a lot of their time.
Can I just ask, should some of these services be available, say, at weekends, so that fathers can attend as well?
Yeah, and I think some of the more successful ones we've seen they run it on a Saturday morning, which is really good, again, because predominantly fathers are more engaged in the workplace on a Monday to Friday. So running those things on a Saturday morning, making it like a family-friendly activity, and often they're running kind of food banks or clothes banks or at the same time, so just really having it as a non-stigmatised place for people to come, but also there is that opportunity to access healthcare services which people might not consider if they were just going to a statutory provider to do that.
That's really great. Job done. Thank you very much. Dr. Jeremy Davies, Simon Yates, Karla Capstick, thanks so much for giving evidence to us and being succinct in your answers. We've got a lot from the session and the previous panel as well. That concludes today's session on our men's health inquiry. To be continued. Order.
Thank you.
The proceeding is currently suspended. The proceeding has ended. 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 The proceeding has ended.